Welcome to this explainer. Today, we're diving into the massive neurological highway that runs right down your arm. We're going to unpack a really fascinating medical review on radial nerve compression. It's basically a journey into the complex and, honestly, sometimes incredibly cramped anatomy of the human upper body. And we'll see how even the slightest physical blockages can just completely derail your day-to-day life.
So, to kick things off, I want you to look at your own arm right now. Go ahead and extend your wrists or straighten your fingers to point at something. You can thank your radial nerve for that. It's the powerhouse sending signals from your spine all the way down to your fingertips. But what happens when that signal gets blocked? Like, how can simply falling asleep in the wrong position leave you literally unable to lift your own hand? Well, to understand these bizarre symptoms, we first need to define the medical baseline for these anatomical traffic jams. The clinical term here is compressive neuropathy. Think of a nerve kind of like a garden hose, but one that carries electricity instead of water. If you step on that hose, or if a rock gets permanently wedged against it, the flow just stops. In our bodies, that pressure can come from the outside world, or it can come from inside us, from our own muscles, tendons, and bones trapping the nerve.
To really make sense of where these blockages happen, we've got to understand the root. This nerve highway actually splits into three distinct paths. First up, we have the main trunk of the radial nerve, which is high up in the arm. As it travels down past the elbow, it bifurcates, meaning it splits, into two highly specialized roads. One is the deep motor branch, also known as the posterior interosseous nerve, or PIN for short, and that carries the motor signals to move your muscles. The other route is the superficial sensory branch, or SBRN, which purely carries sensory signals so you can feel the world around you.
All right, here's our roadmap for this explainer. 1. Meet the radial nerve. 2. High radial entrapment. 3. PIN syndrome. 4. Radial tunnel syndrome. And finally, number 5, Wartenberg syndrome. Let's get right to it.
Section 1. Meet the radial nerve.
Moving on to Section 2, High Radial Entrapment.
Okay, so originating from this huge network of nerves in your shoulder, the radial nerve descends past your armpit and literally spirals around the back of your upper arm bone. It sits in a really vulnerable spot called the radial groove. And when entrapment happens high up here, you get some highly relatable real-world nicknames for the conditions, which, by the way, can cause severe weakness or even complete muscle paralysis. You might have heard of Saturday night palsy. This usually refers to someone having a bit too much fun, falling asleep with their arm draped over the firm back of a chair and crushing the nerve right in that groove. There's also honeymoon palsy, where the compressing factor is just a partner falling asleep on the patient's arm. In both cases, the external pressure is actually crushing the nerve right against the humerus bone.
And taking a look at this, it brilliantly illustrates why a high compression is just so devastating. It cuts the motor power to all these major muscles. Because the blockage happens high up, literally every muscle downstream loses its signal. The extensor carpi radialis longus goes completely offline, which leads to that infamous wrist drop where the hand just hangs limply. And if the compression is high enough, it even knocks out the triceps, robbing you of the ability to straighten your elbow. No way around it. It's a major roadblock.
Now, what's really fascinating here is that even being in peak physical condition can be a hazard. Overdeveloped muscles can physically choke off that nerve highway. The source material actually highlights a wild case of an elite bodybuilder who developed radial nerve palsy not from trauma or a chairback, but from severe hypertrophy. His own teres major muscle grew so massive that it closed off a tiny anatomical window known as the triangular space, pinching the nerve shut from the inside.
All right, Section 3, PIN syndrome.
Continuing our journey past the elbow, that main nerve trunk splits. Here, the deep motor branch, which we call the PIN, faces an absolute anatomical obstacle course as it dives deep into the muscles of the forearm. The PIN has to navigate 5 distinct, incredibly cramped tunnels in tight spaces where it can get disastrously pinched. First, it passes fibrous tissue at the radial head. Second, it runs under a cluster of blood vessels called the leash of Henry. Third, it scrapes past the sharp tendinous margin of the extensor carpi radialis brevis muscle. Fourth, it enters the arcade of Frossi. And fifth, it exits out the distal border of the supinator muscle. Any single one of these 5 checkpoints can swell, tighten, or just clamp down on the nerve.
You can really notice the nerve's precarious path here as it dives deep under the supinator muscle, crossing right under a cluster of red blood vessels. That's the leash of Henry I just mentioned. The muscle bellies completely engulf the nerve. I mean, it's a super tight squeeze, even in a perfectly healthy arm.
So the really crucial takeaway here is that a massive 64.4% of these PIN compressions happen at a single, tough, tendinous arch called the arcade of Fros.
This is essentially the doorway into the supinator muscle. In a lot of people, this doorway is made of rigid, unforgiving tendon tissue rather than soft muscle. So when you do heavy, repetitive manual labor, or say play an instrument like the violin for hours on end, this arch can thicken up. It basically acts like a guillotine resting gently on the nerve.
And when that happens, the clinical presentation is remarkably specific. Because the PNIA is a motor highway, blocking it means you lose the ability to extend your fingers and thumb, resulting in what doctors call finger drop and thumb drop. But curiously, because the sensory branch split off higher up in the arm, you can still feel everything perfectly. You have total sensation, but your fingers just flat out refuse to follow your brain's command to straighten. It's a really strange disconnect.
Moving on to Section 4, Radial Tunnel Syndrome.
Now, we hit a highly controversial medical mystery. This happens in the exact same anatomical location as PIN syndrome, but it presents entirely differently to the patient. So many patients with radial tunnel syndrome, or RTS, get misdiagnosed with tennis elbow. It is a massive diagnostic headache. Tennis elbow is an overuse injury of the tendon right at the bone of the elbow joint. RTS, on the other hand, is a nerve inflammation issue that happens a couple of inches further down the arm. But here's the wild part. Unlike PIN syndrome, which causes muscle paralysis without pain, radial tunnel syndrome causes deep, burning pain with absolutely zero muscle weakness. It's literally the same nerve in the same tunnel, but somehow it generates a totally different biological alarm bell.
So how do we solve this diagnostic puzzle? Doctors rely on physical exams, like the Rule of 9 test. They visually divide the top of the patient's forearm into a grid of 9 squares. If a patient comes in complaining of elbow pain, the doctor tests for tenderness. If the pain is localized exactly in the top 2 or 3 lateral squares of this grid, which, by the way, map perfectly over the radial tunnel, it points directly to the nerve, basically ruling out your standard tennis elbow.
And our final section, Section 5, Wartenberg Syndrome.
Our final stop, we're examining the superficial branch of the radial nerve. This one journeys all the way down to the wrist and gives us our final entrapment. Because this branch is purely sensory and runs right under the skin on the back of your wrist, it's uniquely vulnerable to everyday external pressures. Wartenberg syndrome doesn't paralyze your hand, but it does cause numbness, tingling, and radiating pain. As the source text notes, something as simple as wearing a watch strap way too tightly or wearing rigid handcuffs for an extended period can actually crush this superficial nerve against the radius bone.
But for some people, the danger isn't external at all. There are these incredible anatomical variations where the nerve literally splits right through the muscle bellies or tendons of the brachioradialis muscle, rather than running smoothly underneath it like it's supposed to. Imagine a delicate cable running right through the blades of a pair of scissors. When the muscle contracts during repetitive forearm twisting, it sets up a perfect trap for friction and crushing, literally damaging the nerve with every single movement.
So, as we wrap up this explainer, I want you to consider how a fraction of a millimeter of extra tissue in your arm, or a slightly thicker tendinous arch like the arcata froche, can mean the difference between a totally pain-free life and a complete loss of hand function. We all look basically the same on the outside, but underneath, our anatomical wiring is incredibly unique. So the next time you experience an unexplained numbness or a deep ache in your arm, you really have to wonder, is it just a strained muscle or is there a major traffic jam on your radial nerve highway?